So my name is Joe Maneski. I work here at the Foundation for the National Institutes of Health. And my job is to let you know that this will be recorded. And that's because we want to make sure that we capture all of the comments, all of the bit of the, the important parts of this of the presentation for the future, and for others to think about. We want it to be right. The other is that we will be putting this onto our website so that people can, if they missed this presentation, they can get an encore, or as I do frequently, watch them 2 or 3 times because there's so much interesting data, I miss it the first time. So I appreciate being able to do that. Do want all the attendees will be muted during the presentation, and unmuting will be enabled for Q&A. The best way, though, to do the Q&A we've found is if you could submit questions in the Q&A, which is there's a picture at the bottom of this to help with in either the chat or the Q&A, so that we can, and we'll try to cover what is in there. So as we are moving forward, you don't have to wait to put in your questions. Put them in as soon as they come to you. We will wait to address them until the end of the talk. So if there are, and we'll try to catch them all. So with that, I am going to thank our speaker today for being here, but I am going to hand it over to our host, Dr. J Rappaport and Dr. Josh Fessel, and Jay's from Tulane, and Josh is from the NHLBI. Many of you will know them very well. It's been my pleasure to be able to work with them to put this together. And with that, I'm going to let them introduce our speaker today. So wish everyone a good day and looking forward to a great talk.
Thank you so much, Joe, and thanks so much to the whole team that has put this seminar series together. I remarked recently that this is usually the highlight of my week when we have one of these, and this week is definitely no different. It is my absolute honor and pleasure to introduce Dr. Akiko Iwasaki as our speaker for this week. Dr. Iwasaki is the Waldemar von Zedtwitz Professor of Immunobiology and Molecular, Cellular, and Developmental Biology at the Yale School of Medicine. She's a professor of molecular, cellular, and developmental biology, as well as a professor of epidemiology and an investigator of the Howard Hughes Medical Institute. We could spend an entire hour talking about the awards and honors that Dr. Iwasaki has racked up in her illustrious career. The one that I'll mention in particular is one that somebody is really accomplished when you can talk about awards they haven't even technically received yet. And in advance of this seminar series, the one that's yet to be announced, Dr. Iwasaki is, among many other awards, is the recipient of the National Cancer Institute's 10th annual David Durst Memorial Lectureship and Award. And that's coming up in early November. So if you get as much out of this as I expect you will today, and you want to hear more from Dr. Iwasaki, look for the webinar for that seminar as well. She's co-authored countless manuscripts, by my count, almost 50 just this year. Which is mind-boggling to me, but I think it speaks to not only her incredible impact on the field of immunology and our understanding of immunology, but also her incredible talent as a truly gifted scientific communicator, not only in traditional methods like peer-reviewed manuscripts and book chapters and review articles, but also communicating directly with people. For example, to almost 150,000 people a day on her Twitter feed and through various other social media outlets. And indeed, Dr. Iwasaki was one of the very first people that I heard give voice to the ideas about how the immune system might plausibly be playing some complex and important roles in what we are now thinking about as task or long COVID or post-COVID conditions. And she's been thinking a lot about this and doing a lot of work in this area. And so I am truly excited to hear what you have to say to us today, Dr. Iwasaki. Thank you so much for being here. And please, the floor is yours.
Thank you so much, Josh. That was such an incredibly kind introduction, and I'm really delighted to be here. I'm going to start sharing my screen. Oops, I cannot do this. All right, let's try again. Here we go. Can you see this?
Yes.
I have a great view of your screen.
Oh,
Yes.
wonderful, wonderful. Okay, great. So yeah, I'm really delighted to be here to discuss some of the potential disease mechanisms of long COVID. And this has become such an important issue to think about and to do research on, as millions of people are currently suffering from devastating impact of long COVID. So before I jump into long COVID, I want to emphasize that there are so many other acute infections that have lingering symptoms that have been studied for decades. And this is a manuscript that I'm putting together with Dr. Chotka. And as Josh mentioned, I'm very active on Twitter. And he and I follow each other. And one day, he approached me about writing a review together. And that's essentially what we're doing. He himself is a ME/CFS patient and has done enormous research on the link between pathogens that cause ME/CFS. And so this is from that research paper that we are preparing, review paper that we're preparing. And essentially what this demonstrates are the number of different pathogens that have post-acute infection syndromes associated. And today I'm obviously going to focus on the SARS-CoV-2, PAX or long COVID. Many names are given to it, but there are numerous other pathogens, many viral pathogens, Ebola, dengue, polio, SARS, chikungunya, EBV, as well as non-viral pathogens, bacterial and parasitic pathogens that also result in very long-term debilitating consequences in people. So just want to kind of remind people that this disease that linger after an acute infection is not a new thing, that it's been happening for probably thousands of years without having a name for it. And it's not that all of these post-acute infection syndromes are identical. There are some unique features associated with them. But there are main categories that are well shared between these post-acute infection syndromes. Top one being the fatigue and exertional intolerance, flu-like sickness behavior symptom that persists for a very long time, neurologic and cognitive symptoms, which you'll probably hear from Dr. Farhadian next time. And there are rheumatologic symptoms and trigger-specific symptoms that occur with post-Ebola, post-Giardia, and other post-polio syndromes. And so this is really important to consider long COVID in the context of all these other pathogens, because we might learn something from studying and learning from other causes of long-term symptoms. So jumping into the long COVID, as we are learning on a daily basis, there are so many patients now suffering from long COVID with myriad of symptoms for weeks, months, and over a year now. And the most common being the fatigue and post-exertional malaise and cognitive dysfunction. There are also evidence of multiple organ involvement, which I'll get into. A significant percentage of COVID survivors develop long COVID. And each study you read has a little bit of a difference in the prevalence of long COVID, because we're all defining long COVID with different measures. Some of them have different duration of symptoms that they classify as long COVID. Others consider more than one symptoms, two symptoms, how many ever symptoms that they would, qualify as a long COVID. And there are just multiple different ways we are characterizing this population, and thus we are lacking a concrete number or percentage that we can hang our sort of use it as a valid percentage. However, it's known that a large fraction of people who are hospitalized and discharged from COVID do suffer a large number of symptoms, and 45% of the cases result in reduction in workload and 22% unable to return to work. So this is going to be a severe global problem going forward. So when we think about long COVID, I just want to hypothesize or highlight that there may be a couple of different pathobiology associated with different ways a person might get to the long COVID symptoms. So people who have severe COVID symptoms who are hospitalized and discharged, 50 to 70% of these people have lingering symptoms for months after discharge. And we can consider these as post-severe COVID-19 syndrome, which may be accompanied by significant fibrosis, tissue damage, organ damage, and post-ICU syndrome-like syndromes. Whereas the other kind of long COVID that happen on the bottom here happen with mild or potentially even asymptomatic COVID that can then have long-term symptoms. And again, the estimate go anywhere from 5 to 35%. But roughly 10 to 30% of the people who have had mild or asymptomatic COVID might succumb to long-term symptoms. And this can be considered post-COVID-19 fatigue syndrome. And it's important to sort of think about these two types of long COVID separately, because not only the pathophysiology might be different, but the demographics appear to also be different. And so when you look at the post-severe COVID-19 syndrome patients, there is a very nice systematic review that revealed that 54% of COVID survivors have these post-acute COVID syndromes. And this is just a graph that I took from this JAMA paper that looks at the follow-up time on the x-axis and the frequency of PASC on the y-axis. And you see that there is a huge spread, as I mentioned, of the frequency, depending on which study you look at, and it probably depends on how people are defining long COVID or PASC. However, you see that even up to, even after 200 days post baseline, you're seeing this particular paper, 75%, this from Germany is below 25%, but a large fraction of people are still suffering from long COVID. And so this is, 250,000 survivors being sort of followed up in this manner, kind of highlighting the importance of this disease and trying to understand the basic pathogenesis. And if you look at other studies, there are so many studies, I cannot cover them all, but just to highlight some of the other studies, it appears that middle-aged women do face greater risk of debilitating long COVID. For instance, this study by Evans et al. Looked at different demographic factors and saw that, for instance, age at admission, so people who are in the middle age group, 40 to 60-year-olds, have a less likelihood of recovery from COVID symptoms. And being female had a much more higher risk for developing lung symptoms. And this particular study found white ethnicity, to be more associated with lack of recovery, but other papers found different things. Women on the right, I'm showing you another study that demonstrates that women under 50 are 5 times less likely to report recovery from symptoms, and twice as likely to report with fatigue and so on and so forth than males from the same age groups. And looking at the sort of post-COVID-19 fatigue syndrome cases, there are many studies again, but this one, for instance, highlights the fact that the risk for a lower baseline level of SARS-CoV-2 IgG, anosmia and diarrhea during the acute COVID were associated with higher risk of developing long-term symptoms. So this is interesting because I'm going to get into the hypothesis about the pathogenesis, but having lower baseline level of SARS-CoV-2 IgG means that it's potentially possible for these people to have failed to clear the primary infection that may be leading to some of the long-term consequences. And having anosmia and diarrhea, does it mean that tissue-specific features of this infection may also contribute to long COVID? And this study again showed that male sex was associated with a lower risk for developing long COVID. So there are over 200 symptoms reported for long COVID. And this is just some of the typical symptoms that are listed on this table. And you can immediately determine that there are so many organ systems involved to have created these symptoms and manifestations. So fever, fatigue, post-exertional malaise, these are the, one of the typical symptoms that people report, as well as many neuropsychiatric issues, cognitive issues, head, eyes, ears, nose, and throat, endocrine, cardiovascular, pulmonary, musculoskeletal, GI tract. So essentially, this demonstrates that a acute respiratory infection with the simple virus can lead to so many different symptoms that involve multiple organs. And it's also important for us to, as a community, to understand whether there are sort of multiple different diseases that underlie long COVID, and that potentially by clustering patients based on the symptoms, we might be able to get at the pathogenesis better, because, if you bunch together all these different clusters of diseases and trying to study them, we might not be able to reveal the underlying biology. Whereas if we are able to cluster patients based on different symptomology, then that gives us a little bit more easier path towards understanding the disease itself. So the long COVID symptoms and severity have been followed over months. And what this graph here shows on the left is that over time, the severe and very severe symptom decline and replaced by more milder to moderate symptoms. And but unfortunately, you can see that there's a flattening of the curve, ultimately showing that many people still suffer from consequences of long COVID months after acquisition. And another interesting fact is that the average number of symptoms that people start off with, if that average number was less than 12, for instance, there is more likelihood of these people to recover within 90 days, whereas people starting off with 13 or more symptoms continue to accumulate more and more symptoms and are not recovering within 90 days, demonstrating that perhaps the involvement of different organ systems at the acute phase will dictate the longevity of these types of symptoms. And this study also tracked different symptoms over time. And as I mentioned, fatigue, shown in green here, is one of the most dominant symptoms that's reported. And still over 80% of the people are suffering from fatigue months after the onset, whereas some other symptoms like fever decline over time. And there are, as I mentioned, many different respiratory, gastrointestinal, and dermatologic cardiovascular involvement. And there are also reproductive and endocrine symptoms that are reported, especially affecting menstruation and other issues in women as well. And there are again, numerous other system involvement that's indicated here. Of course, the neuropsychiatric, cognitive, and sensory motor, as well as other neuropsychiatric symptoms are very prevalent in the long haulers. They also monitored or surveyed for new allergies and new anaphylactic reactions. These remain relatively rare, but it doesn't mean that autoimmune disease isn't happening in these patients. That's something that we are currently working to try to understand better. So what could be the cause of long COVID? There are a couple of major hypotheses that I'd like to share with you, but it's not an exhaustive list of hypotheses. One is the establishment of viral reservoir. So we know that the long haulers have no longer detectable viral levels in their nasopharynx or in their saliva. However, it's possible that there are infectious viral particles or remnants of virus, RNA, protein, combination thereof in various different tissues. And if that were to happen, there may be chronic inflammation that occur in those tissues that result in long-term symptoms. And this could also trigger organ-specific features, such as respiratory versus GI tract, neuropsychiatric versus something else, skin. So that's something that is a possibility. Another hypothesis is that the acute viral infection triggers autoimmunity. And this autoreactive lymphocytes could either be T or B cells or both. And they may target different organs or tissues, cells within these tissues that might trigger long-term consequences and may certainly drive many of the symptoms that are reported. There are many other hypotheses, including tissue damage, dysbiosis of microbiome, virome, and others, as well as latent viral reactivation that are often reported in long haulers. And so, we currently don't know what's driving what, but our goal is to try to understand if any of these hypotheses hold true. So there's evidence for both the reservoir and the autoimmunity in long COVID patients. This is a graph that I took from a study where they looked at intestinal biopsies from people who've had COVID and are convalescent, found that 5 out of 14 patients had detectable positive staining for viral nucleic capsid, which is shown here beautifully in the enterocytes. And they also found 3 out of 14 people with PCR positive viral RNA after 3 months of recovery, indicating that these kinds of viral antigen and RNA, or potentially even infectious particle, might be established in patients. Another study which looked at different biopsies or surgical specimen from convalescent patients also detected in numerous tissues viral protein and RNA, and again, many of the GI tract tissue as well as lymph nodes, again, indicating that the possibility of a viral reservoir or viral ghost, which may persist in different tissues to trigger inflammation. We and others have looked at the possibilities of autoantibodies. So during acute COVID, we already demonstrated a number of autoantibody, very diverse set of autoantibodies that develop in these patients. And this study was done in collaboration with Aaron Ring, who's a professor in our department, and his lab members and my lab members together probed for the presence of autoantibodies. This was enabled by the technology called rapid extracellular antigen profiling that was developed by Dr. Ring's lab, which utilizes yeast display library that expresses over 3,000 human exoproteome, which is a collection of proteins that are either extracellular or secreted. And now he has accumulated over 6,000 exoproteome. That's the version 2.0, but this study used the one that was 3,000. And what you do is a very simple and high throughput. We collect IgG from the plasma or sera from patients, and then we incubate that with the library and pull down the yeast cells that are bound by the IgG using magnetic beads. And then you can decode the antigens that this cell was expressing using deep sequencing. So this enabled very high throughput and reliable way of looking for autoantibodies in COVID patients. Using this analysis, we found, like I said, a number of autoantibodies. Here I'm just showing you the autoantibodies against tissue-specific antigens, but we also identified numerous immune factors that are targeted by autoantibodies, including the type 1 interferons and cytokines and even leukocyte cell markers that appear to deplete the subsets of cells, the very cells that they need to combat a viral infection. But here, what I wanted to emphasize is that, so each column is a patient and each row is an autoantigen. And the brighter the yellow, the more autoantibody there is in that particular patient. And this is an acute COVID patient that's divided into severe, moderate, mild, or asymptomatic. You can see that there is a scattering of different autoantibodies that develop in many of these patients. Some of them occur very commonly, while others are pretty unique to the patients. But just demonstrates the fact that during acute COVID, we're seeing this large array of autoantibodies that could have a specific disease pathogenic effect within those patients. So we are now currently following up these patients after over a year from the study to try to understand what the long-term consequences of having had these antibodies are, as well as whether they still have these antibodies. And we're not alone in finding autoantibodies in acute and long COVID. So there are a number of studies that have already identified a variety of autoantigen target during acute COVID and also during long COVID. So the last paper that I list here from Journal of Translational Autoimmunity found functional autoantibody against G protein coupled receptors in all patients that they've looked at with persistent long COVID symptoms. So this kind of G protein coupled receptor autoantibodies have been seen in a number of other diseases that obviously impair or dysregulate the signaling from a number of cell types that may be affected by such autoantibodies, cardiovascular functions, neurologic functions, and so on. So there's now ample evidence that this can happen in long COVID patients as well. So there are also some studies taking a look at the inflammatory and immune signatures of PASC. And this study by Michael Peluso et al. Followed patients who have either PASC in red or no PASC, but are convalescent healthy individuals in blue. And they looked at the early time point versus late time point cytokine in their circulation. And what they found is that IL-6 was maintained high in PASC patients, even at late time point. Whereas other cytokines they looked at were not significantly different either at the acute or late stage. And also importantly, there wasn't a big difference in the SARS-CoV-2 IgG levels in PASC or no PASC patients. And so this is interesting in light of the fact that in ME/CFS, there has been report much longer, obviously, timeline in ME/CFS, but have been report of sort of acute levels of IL-1 alpha and TNF with a declining over time, as well as IL-6 being sort of lower levels in the beginning, but continue to rise over time. So these features are maybe shared in the patients with long COVID. Obviously, it requires a lot longer monitoring of these patients to know if these features also hold for PASC. And there are also the same group published another report demonstrating what happens to T cells. So these panels, the white dots indicate people with no persistent symptom at the latest time point versus green dots indicating patients who have PASC at 125 days post follow-up. And each of these are indicating, for instance, anti-nucleocapsid or anti-spike CD4s and CD8s at early time point on the top and later time point on the bottom. And essentially, there is very little difference in any of these T cell parameters, except for potentially the percentage of interferon gamma negative CD107 positive memory T cells at one of these time points. So indicating that there's nothing like overtly different about the T cell responses that we see in PASC patients, whereas circulating cytokines may be used as one of the markers for PASC. What about other aspects of the immune cells? This is another study on medRxiv that demonstrated that there are some immune cell subsets, such as the T follicular helper cells. So T follicular helper cells are very important in providing help to B cells. And this is a very important mechanism for generating antibodies that are highly effective in clearing the virus and binding and neutralizing the virus. And in this study, what they found is that there is a sort of time-dependent increase in the TFH, the follicular helper cell subset over time against the nucleocapsid of SARS-CoV-2, whereas in the healthy convalescent, this number actually declines over time. And sort of consistently, there is an elevated level of anti-N IgG in the neuropasc patient compared to convalescent healthy patients. So potentially giving us some clue for the persistence of at least the nucleoprotein in PASC, and that there is a continuous sort of engagement of the TFH and antibody response. Also, the same paper demonstrated that there is reduced CD8 T memory subsets, the T effector memory and the TEMRA, which is a terminally differentiated CD8 T cell subset against the viral proteins in the neuro-COVID patients compared to the healthy convalescent controls. So altogether, this may suggest persistent viral antigens that are driving the development of TFH and antibody response against the nucleoprotein. At the same time, because of having chronic levels of antigen, reduce the percentage of the memory cells that we can find in circulation. However, this is all hand waving, as I'm literally hand waving. We don't know. I mean, right now, I'm still completely open to all possible hypotheses of long COVID. So this brings to the question, are there any treatments that impact long COVID symptoms? And there is one such thing that I've noticed from very early on, that patients were reporting improvement in their long COVID symptoms after vaccination. And this is a very nice survey done by Long COVID SOS, a patient-led group that surveyed their patient group for symptom changes after vaccination. And this graph demonstrates that upward of 60% of the patients who got either the adenoviral, Moderna, or Pfizer vaccine reported improvement in their symptom, whereas about 19% had worsening of the symptoms and the rest no change. So this illustrated that regardless of the type of vaccine, the long COVID symptoms are being modulated as a result of vaccination. And when you break down the different kinds of symptoms with respect to improvement after vaccination, there is a slight difference. For instance, the Moderna seems to have a very high impact on fever reduction, muscle pain, and so on, whereas other symptoms are relatively similar between these vaccines. There's also another preprint out there that demonstrated recently that vaccination in long COVID patients seems to double the rate of complete remission in long haul symptoms. And this is a study that simulated target trial of the impact of vaccination in long COVID patients based on a data set called COMPARE. And using this simulation, they basically demonstrated that the complete remission was much higher in patients that got the vaccine than those patients who did not. So how can vaccines impact the symptom of long COVID? Well, going back to the two major hypotheses, if there is a viral reservoir that's being set up in these patients, then vaccination will induce robust T-cell and antibody responses that might clear the reservoir. And that would lead to a permanent solution. It's also possible that the vaccines might elicit cytokines and interferons that modulate the toxic impact of the autoreactive T and B cells and dampening down their sort of pathology, at least for some limited time period. And so there's evidence for both. Some long haulers say their symptoms are completely resolved, while others, after vaccination, while others are saying that the symptoms improved for some time period, but then it came back again. So right now, again, we don't know how much long COVID can be explained by one or the other hypotheses, but there appears to be sort of evidence for both of these things occurring. So currently, my lab's mission, in collaboration with a large number of groups, is to understand immunological and physiological determinants of disease pathogenesis of long COVID in order to inform rational diagnosis and therapy. Without the clear molecular understanding of disease pathogenesis, it would be very difficult to come up with a therapy that would work in a given individual, especially because we think that this long COVID is a heterogeneous disease, and targeting the right pathway in the right patient would be critical going forward. So we have now established 3 cohorts of long COVID patients that looks at different angles of disease pathogenesis. So first cohort is a cross-sectional long COVID cohort. This is in collaboration with Dr. David Petrino in the Mount Sinai School of Medicine, where he gives rehabilitation therapy to thousands of long COVID patients. And we are currently collecting symptoms and blood from these patients in order to try to understand what features of immune parameters correlate with what symptoms. The second cohort, cohort B, is a longitudinal long COVID vaccine cohort. We also call it the Yale Recovery Cohort, where together with Dr. Harlan Krumholtz, we are recruiting patients who have long COVID, but have not been vaccinated yet, and collect their blood before and after the first dose of vaccine, 6 and 12 weeks post first dose, to be able to monitor the changes in their immune response and correlate that to symptom changes. And the third cohort of patient, which we're calling longitudinal symptom-based long COVID cohort, is again with Dr. Krumholtz. We are now establishing a large patient electronic survey base where we can leverage social media and other advocacy groups to recruit long haulers into the electronic survey And then once we have enough number of patients, we can target those with specific and severe symptoms that may involve, let's say, the neuropsychiatric or GI tract or skin disease, or whatever the extreme symptoms might be. And then we are going to contact them and consent them to get specimens from these patients. And the power of this strategy is really to try to target the symptoms and really hone in on the right kind of immune parameter as well as metabolic parameters that may be underlying these symptoms. So I think all three types of approaches will be very synergistic in revealing the pathogenesis of long COVID. And just to introduce some of the key players in each of these cohort studies, this is the David Petrino group from Mount Sinai, and we are on a daily constant basis communicating with their team to recruit patients and convalescent healthy controls. This is the team for the Yale COVID recovery study. Harlan is the lead on this, and Daisy Massey is the program coordinator. And we are recruiting locally right now, but hopefully we can expand this nationally to be able to collect more samples. And all of these things are done in collaboration with the patients. And this particular study is done in collaboration with both the Survivor Corps as well as patient-led research collaborative. And as I mentioned, from this particular cohort, we are going to collect, or we are collecting, a pre-vaccine and 6 and 12 weeks post first shot vaccine, saliva, blood, and symptoms. And we're analyzing every immune parameter you can imagine to try to understand the changes of their immune parameters to the symptoms. And so a lot of the cohort studies that I mentioned are really focusing on the post-COVID-19 fatigue syndrome. However, we have one cohort that we are pursuing right now called Long Impact Yale. And so the Impact Yale is the biorepository that enabled us to identify so many different features of acute COVID disease as well as immune responses. And we are now following patients well over a year from their discharge to be able to understand what changes have happened in these patients, what symptoms they're still suffering from, as well as what immune parameters have changed. So we have the acute disease phase immune parameters that we can compare to the much later phase and try to understand what is correlating with the long COVID symptoms in these patients. And we suspect that a large percentage of these patients would have long-term symptoms based on all the studies that are published on the post-severe COVID-19 syndrome. And that long impact collaborators are listed here. And these are sort of also the impact collaborators, the acute impact collaborators that have provided so much insight already into the acute disease. And so we are very fortunate to keep on collaborating with this team. And so the workflow is to collect biospecimen from patients. And then this is in collaboration with, like I said, many lead investigators as well as patient groups, and do a real-time flow cytometry analysis to look at cell types and activation status. And then we will store the rest of the samples for further analysis of a lot of those high throughput screening and research phenotyping, as I mentioned before, including the REAP for autoantibodies, T-cell receptor sequencing and mapping with adaptive biotech, metabolomics and hormone profiling with Ruslan Mezitov, and also doing a sort of whole serum analysis of reactive antigens with Serimune. We're also, once we have identified all these parameters, we are collaborating with computational scientists who have the expertise to do integrative multimodal data analysis and correlations. So this is really it is a large team effort that we are embarking on. And finally, when we have these data, we want to share the data back to the patients. And we really want to involve patients as equal partners in all of these investigations. And I have to say that I've learned so much over the last many months from talking to and interacting with patients. And patients are the experts of their disease. And I really appreciate every opportunity that I have to interact and learn from them. So the least we can do is to provide the data back and to involve them in the actual analysis and sharing of the data. So I want to end here by thanking my amazing lab members who've been just fantastic and inspirational to work with. And the impact team, which includes Dr. Farhadian, as well as others that I mentioned along the way. And then the 3 different cohort teams without whom we cannot do any of these long COVID studies, as well as patient-based groups. And this is a picture that we took after everyone was fully vaccinated, and HHMI for their generous support. So thank you so much for your attention.
That was incredible. Thank you so much. I'm so glad this was recorded because there's no way I could have taken notes fast enough. I knew this was going to be good because we were getting questions before you even started talking. So we do have time for a few questions, and I'm going to try to address as many as I can, take them in order, and sort of group some of them. I'm sorry for those that we don't have a chance to get to. We try to address questions as fully as we can in some of our follow-up activities as well. But while we have you here, Dr. Iwasaki, I'm going to group a couple of the questions that have come in the Q&A under the broad heading of variability and thinking about what drives variability in how people experience flares or resolution of long COVID symptoms. We've had some questions on why do some people, what are your thoughts on why some people experience flares when they have a secondary infection, a cold, the flu, something like that, or even a different vaccine? Or your thoughts on why some people experience such robust resolution of symptoms and others don't, and why some people it doesn't last? And so where do you think the right places are to look for the sources and drivers of those variabilities?
Yeah, those are excellent questions. We obviously don't have an answer to that yet, but some of the variability could be, so it's very interesting because some people get worse from the vaccine or even catching a cold, while others get better. And what is the difference? One possibility is that people who, let's say, have autoimmune type of long COVID may get a flare-up when there is enough inflammation caused by other things like vaccines or cold, or that's one possibility. And as I mentioned, like if it's COVID specifically driven, then the vaccine for COVID should work to resolve these issues, whereas a flu vaccine may do nothing. If it is a bystander cytokine mediated suppression of autoreactive cells, then any inflammation could help as long as it induces the right kind of cytokine. So it's a very complex question, and hopefully with the angles that we're taking, we'll be able to, first of all, cluster the patients based on the different symptoms or different organ involvement that they're having, and then to ask this question again in a more intelligent way, because right now I feel like we're dealing with such heterogeneous diseases all in one bucket, which is making it hard for us to understand the disease pathogenesis.
Excellent, thank you. That's great. We've had a couple of questions from a few people about the topic of thromboses, and in particular microclots or microthromboses. Can you talk a little bit about how you think about the role of inflammatory signaling in immune responses as a contributor or even protective, and where does the immune system and the clotting system intersect, and how can we better tap into that?
Yeah, that's another great question. So the clotting is part of the immune system. I mean, we try to block infection through multiple different ways, and clotting is one of the sort of ways in which the immune system uses to confine a pathogens or repair tissue, and particularly stop the bleeding, obviously, from a infection or tissue damage. So it is intricately involved with the inflammation system. So even inflammatory cytokines alone can activate endothelial cells, platelets, all the factors that are involved in clotting. So it could be just sort of having this chronic level of IL-6 and other things that I mentioned that could be driving chronic inflammation that's predisposing to clotting. It's also possible that there may be some sort of antibody complex that's being generated. If there's a chronic level of viral antigen somewhere, that may be depositing into different tissues and causing clots there. There are so many possibilities that we don't really understand yet, but platelet activation may be one of the key issues.
Excellent, thank you. Yeah, I really appreciate your thoughts on that, because I think the two things that often are most puzzling to people when they're learning human biology are the clotting system and the immune system, and bringing them together takes incredible expertise. So your thoughts on that are really appreciated. We've had a couple of questions come in from people that I will sort of put under the umbrella of distinguishing post-COVID conditions or post-SARS-CoV-2 infection symptomatologies and long COVID from other post-infectious conditions. And there's been specific mention of, for example, post-ICU syndrome. Can you talk a little bit about how you think about the right ways to, and you've spoken a little bit about this in the talk, but I wonder if you could expand a little more on what are some, how can we be savvy, particularly in our research activities, but also thinking ahead to diagnostics and that sort of thing, about being as correct but also as inclusive as possible in terms of thinking about long COVID versus other post-infectious syndromes?
Yeah, so I sort of mentioned a little bit about the other post-acute infection syndromes, but they tend to have a different dominant symptoms other than the ones that are very common, as I mentioned, fatigue, post-exertion malaise. These are very common among all of these. But for instance, the post-COVID syndrome does appear to involve more encephalopathy and myocarditis, as well as loss of smell and taste. This is very, very typical of post-COVID, whereas that's not necessarily the case with other pathogens. So there are symptoms that are more highly associated with post-COVID syndrome and others that are shared. And so that's the other complexity, like how do we untangle all of these post-acute infection syndrome? And just to sort of highlight the fact that we as a scientific community haven't invested a lot in trying to understand other types of post-acute infection syndromes. So we don't, we do have a lot of surveys and data, but we don't have the immune parameters, for instance, right, at the level that we have for COVID. I mean, COVID has really just revolutionized the amount of attention given to any particular virus ever, right? So there's so much data and so many deep profiling out there, but it's not the case for all the other pathogens. So we have to do some catch up to try to understand what happens with these other pathogens, and at the same time trying to, push forward post-COVID syndrome. So I think we have a lot to do.
I definitely agree that there's a goodly amount of work to do, and I think we're all trying to get after it as quickly as we can. I can't tell you how lucky we are to have people like you and others involved in this. It's going to take all of us and then some. And I really appreciate your time talking with us today. There are still questions coming in. We could do this for another hour, I think, but we have certainly all learned a lot, and thank you for all of your time. Please, for those of you who enjoyed this, tune in next time. For the next talk in our seminar series, we will try to address questions that we didn't get to here in some of our follow-up activities. And several people have asked about accessing the recording. Trey, I think, posted the link to the webpage. The recording will be posted there for later viewing, and other follow-up materials we'll post there as well. And so let me just again finish with a huge thank you, Dr. Iwasaki. This has been tremendous. Just cannot express our gratitude enough. Huge thanks to Jay, to Courtney, to Trey, to John, to Joe, the whole team that put this on, and hopefully we'll see a whole lot of you for the next one as well.
Thank you so much. Thank you.